Dear chairs and attendants, one of the main causes of neuronal injury is related to preterm birth and intraventricular hemorrhage, IVH. My name is Zsuzsanna. I have been working in the neonatology field for 17 years now. Routine IVH detection via bedside ultrasound is an easy diagnosis, but facing a severe IVH, it hits like a lightning out of the blue. It is a therapeutic challenge and as well as a very heavy emotional burden on the family. That's why I decided to focus on the onset of IVH in the hope that we can develop more effective preventive measures and more successful neuroprotective interventions targeting to reduce the occurrence and the severity of this devastating condition, thereby increasing functionality and quality of life in the future. My supervisors are Miklos Szabó and Arjen Töpász. My SMSs are Vanda Máté and Mahmoud Obaidat, and my statisticians are Tamás Kói and Dániel Veres. In the topic of neonatal neuroprotection, we primarily focused on investigating the onset of IVH in preterm neonates. After a thorough analysis of the literature, we will conduct a multicenter international clinical trial. Now let's address the elephant in the room, IVH. As I mentioned before, my field of interest is preterm neonates under the gestational age of 32 weeks or birth weight up to 1,500 grams. IVH is a frequent complication of prematurity, with the pooled estimates of 34.3% among extremely preterm neonates. The main problem is that the exact onset is unknown, but we do know that 90% of the IVH cases occur within the first 3 days of life. That's why our aim is to investigate the onset of IVH in this vulnerable population. On the left side of the picture, you can see a normal ultrasound of a preterm neonates, what you wish for to every preterm. And on the right side of the picture, you can see a left-sided grade 3 and a right-sided grade 2 IVH of a preterm neonates. Our clinical question focuses on the time distribution of onset of IVH in preterm neonates within the first week of life. We hypothesize that there is a typical time distribution pattern of IVH. Here you can see the flowchart of my article selection process. In the end, we found 60 studies eligible for data extraction. First, we calculated the overall any grade IVH occurrence among all preterm neonates. Here, we could include 58 studies, almost 9,000 patients. In the subgroup analysis, the results of studies before and after 2007 were compared. In this way, the majority of the studies in a subgroup before 2007 were included in the previous meta-analysis written by Samir Adabdi in 2014. So the any grade overall IVH occurrence was 36% in the era before 2007 and 29% in the era after. The overall severe IVH occurrence was 10% in both epochs. So IVH remains a significant problem in this vulnerable population, as improved survival of an extremely preterm infant has resulted in a greater number of survivors with this condition. Our primary aim was to describe the distribution of the onset of IVH. Just to fulfill this aim, we pulled individual survival curve from 58 studies just to have a better estimation of the onset of IVH. Occurrences with standard errors of IVH were calculated and pulled at different time intervals. The IVH rate up to 6 hours of life was 35% in the era before 2007 and 7% in the era after 2007. So this statistically significant results translates to a 5-4 degrees in a very early IVH occurrence among all IVH cases. Let's see the other intervals results. So up to 24 hours of life, the IVH rate declined from 44 to 21% in the year after 2007, and the IVH rate up to 48 hours of life declined from 82 to 47. I have to say that the previous meta-analysis, they reported that 48% of the IVH cases occur within the first 6 hours of life. According to our results, we can say that 47% of the IVH cases occur up to 48 hours of life. Several attempts were made to contact the authors of published studies for additional data, and thanks for their large number of answers, we managed to collect individual data from 13 studies. Our main limitation is that the detection time is not equal to the onset. So we can conclude that the any grade or severe IVH occurrence hasn't changed significantly over the past decade. Our findings indicate a substantial 5-fold reduction in a very early IVH occurrence after 2007. So the main message is that our current measures rather delay the onset than prevent IVH. There were high heterogeneity across studies, suggesting a need for standardized reporting for cranial ultrasound. We must perform a cranial ultrasound at very early age. And in future clinical research, timely detection of IVH in preterm infants may help identify a combination of multiple risks and effective interventional measures. Shorter temporal interval is required to find time-specific risk factors of IVH. The shorter the interval, the less confounding factors can interfere. And there is a need for novel technology for real-time diagnosis of IVH, of course, preferably some non-invasive techniques. Our manuscript is under internal review at the moment. Our targeted journal is the JAMA Pediatrics. After a thorough analysis of the literature, we will conduct a multicentric clinical trial with the Netherlands just to gain a deeper understanding on the onset of IVH. First, we will write a clinical trial protocol of IVH screening. As I mentioned before, IVH is a frequent complication of prematurity. There are antenatal, perinatal, and postnatal risk factors known to increase the incidence of IVH. But again, the main problem is that their time-specific effects are poorly described. That's why our aim is to describe the onset of IVH and identify time-specific risk factors under the gestational age of 29 weeks. We hypothesize that both in individual and population level, better knowledge on the onset of IVH will help us gain deeper understanding of the contributing factors at pathomechanism of IVH, and this will help us better evaluate time-dependent risk factors and the implementation of effective preventive measures and interventions in the future. With our collaborators, we already agreed on to include inborn preterm neonates under the gestational age of 29 weeks. We are planning to perform serial cranial ultrasound, especially within the first day of life. I'm planning to submit my first project in February and the second one this year, September. I would like to thank for your attention with the quote. Another thing very injurious to the child is the tying and cutting of the navel string too soon, which should always be left till the child has not only repeatedly breathed, but till all pulsation in the cord ceases. As otherwise, the child is much weaker than it ought to be. Thank you very much.
Why did you subgroup these studies based on the 2007?
Oh, yes. Yeah, okay, so we found a previous meta-analysis written in this topic, which was published in 2014. Their last study was published in 2005, what they could include. So basically, we want to have a comparable. And I didn't check, I'm not just was checking the publication date of this study, I checked the study date. And that's why is it 2007. It's basically we have more or less the same study in the before 2007 group than Samira Dabdi et al. That's the reason.
And based on your experience, why do you think there is a 5-fold decrease in IVH after 2007?
I think we are really good. It's at stabilization of a preterm neonates. We improved a lot on it, and because we can manage to. So we have more extremely preterm neonates, surviving neonates. So we should have more babies with severe IVH, but we don't. So basically, I think there is an improvement in any field, in any perinatal, antenatal, and postnatal field. So we managed to delay the onset. So we hope that that's a therapeutic window to develop some interventions which really can decrease the IVH occurrence altogether.
If somebody does 2 meta-analyses, that's very good. 3 even better. But if the knowledge that you gain during the first meta-analysis, actually the methodology, the way of thinking, and so you can utilize actually in a kind of clinical work. This is where actually this is very important for us. Both for the CTM, both for the kind of people who are, the scientists who are involved in this, and both for the university. And this is especially interesting if this is an international study, but it always brings difficulties. There are not very many international studies actually which are running. So you show very little. Can you tell us some of the advantages and the difficulties when you run a kind of international?
We are not ready. We are just at the planning phase. Yeah. At last, we found really good experts in this field, a Dutch supervisor, and there is neonatologists who are neurologists as well, Silke Stegede and Arjen de Pas I'm talking about. And so we will, just found it out when I'm finished my meta-analysis completely, when I'm submitted, we will write this protocol up and then start it. I won't say that it's going to be easy, I guess.
Okay. But where the data will be collected? Where the real study? In both places?
Yes, yes.
That's good.
Yeah.
Good, and those are difficult.
Yes, yes.
Okay.
We should see. Thank you.
You mentioned novel technologies that can diagnose the IVH. Do you have something on mind, something specific?
Yes, I would like to see our preterm neonates like a Christmas tree. Lots of things on them like near infrared spectroscopy, EEG, and pressure monitoring, arterial pressure monitoring, and so on. But it's a lot. So we will start just to perform that huge amount of serial ultrasound at the beginning, and we will see can we move forward or not. Thank you.